The next speaker in this section is Dr. Alex Valadka. Dr. Valadka is from VCU. He did his medical degree at the University of Chicago, did his residency training at then Medical College of Virginia. I had the pleasure of getting to know him when he was in Houston at Baylor College of Medicine, neurosurgery, and then he was vice chair at University of Texas Medical School in Houston, and went on to lead in Austin, Texas, the Brain and Spine Institute as the CEO and chair. And then recently, about a year or so ago, returned sort of to his roots in Richmond, where he's professor and chair of neurosurgery and currently works in neurotrauma and critical care. He's also president-elect of the American Association of Neurological Surgeons. Welcome, Alex.
Thank you. All right. Is that working here? Great. Yeah, we're good. All right, thank you. So originally, when this meeting was being put together, I was assigned a different topic. I thought this would be a fun talk to give, and then as things evolved, I had to change. I wanted to keep this slide anyway, just because it's kind of a cool picture down there. I also need to thank Mike and all the other organizers for inviting me. You know, this morning in my hotel room, I was listening to the local public radio station, and actually had a story about this meeting in a brief interview with Dr. Friedlander, and I thought that was a great example of the impact that Virginia Tech and Fralin have had in this area, and also Mike's impact here in building a very large and vibrant neuroscience program. So Mike, thank you, and thanks also to our colleagues from Scandinavia who came all the way to be here. This meeting couldn't have occurred without your help. So I'm gonna talk about something a little bit different. I'm gonna talk about traumatic brain injury. And you may wonder, well, who cares? And I know this is a very basic science-oriented meeting. A lot of you are already looking at your laptops and your cell phones and tuning out. But let me ask you, what kills people in the United States and in most Western countries? What do they die of? Well, number one is going to be vascular disease. If you lump heart attack and stroke together, that's number one. Number two is cancer. Number three is trauma. And especially in a younger age group, people ages 1 to 44, they die of trauma. You know, they're too young to have strokes and heart attacks, basically. And if you look at all trauma patients all together, what's the single reason that most of them die, the most common reason? Brain injury. So this is, you know, used to be called a silent epidemic, and then with the wars in the Middle East and the attention in the NFL, it's gotten a little more attention, but it's still not quite widely appreciated how big a problem this is. Now, this is a precision medicine conference. And unfortunately, in terms of brain injury, this is about as precise as it gets. You know, the Glasgow Coma scale, which Sir Graham Teasdale developed over 40 years ago. So we've heard some fascinating talks about people measuring electrical activity in single neurons and really drilling down into microcircuitry and things in the brain. We don't do that in trauma. We basically do a physical exam, as Dr. Korshets mentioned. It's a phenotype. And if you meet a certain coma, in other words, if your depth of coma is deep enough, you get enrolled in a clinical trial. That's it. You know, very imprecise, no imaging or anything like that. So let me give you an example and maybe put that in perspective. What if you're a 65-year-old man, you're obese, you're hypertensive, you're diabetic, you smoke, you suddenly develop crushing substernal chest pain, runs down your arm, goes to your jaw, you're sweating, you're short of breath, you have this feeling of doom. What's the diagnosis? You don't have to be an MD to figure this out. Heart attack, figures having a heart attack. So in this world we live in, this imaginary world, how is that patient going to get treated? The answer is with antibiotics. Because somebody somewhere figured out that if you have pneumonia like this patient has, you get better with antibiotics. So by extension, some patients with chest pain get better if you give them antibiotics. So that becomes a treatment. All patients with chest pain get antibiotics. And you don't care if the chest pain is from pneumonia or heart attack, or a collapsed lung, or a rib fracture, or lung cancer. You kind of lump it all together. And that's the state of the art right now of severe brain injury. So this is a famous slide that was put together by Jeff Manley. He's a neurosurgeon at UCSF, and Elisa Jean's a neuroradiologist. So if these are all 25-year-old men, and they all have a Glasgow Coma scale score of 6, which means they're all in a severe coma, a deep coma, they're all going to get enrolled in the same clinical trial and receive the same treatment. Now, does anyone think these are all the same disease? So look here, this guy's got a big acute subdural hematoma like we just saw in the last slide. This guy needs an operation. This is diffuse axonal injury. This guy probably doesn't need much at all. This is severe diffuse brain swelling. Again, it's like trying to treat heart attack and pneumonia and collapsed lung all with one drug or one treatment. So we're just now starting to drill a little bit deeper, and there are some efforts underway to try to tease out some of these differences. Now, I actually got into this field because I think the pathophysiology is fascinating. This is a patient, Mike, when I was at Baylor from the ICU, monitoring all sorts of physiologic parameters in there. You know, microdialysis and blood flow and jugular vein oxygen. We were one of the first places in the country to do brain tissue oxygen and temperature and on and on. And that's one way of trying to drill down, at least in the physiology, get a little bit more precise, but it still hasn't gotten us very far. This is what the cancer guys have. You know, they can really get down into the genetics and try to figure out what types of cancer we have. But, you know, the analogy, you know, if you or your family member has cancer, they can tell you what stage and what grade. And all we can tell you in trauma is it's bad. It's bad cancer. It's really bad. Again, it's not going to be helpful for guiding treatment. So we need to think differently. And we owe a lot of credit to our colleagues in Scandinavia for thinking differently. Lundberg was one of the pioneers in direct measuring of intracranial pressure with ventriculostomy catheters, and it's still a cornerstone of our treatment today. TBI is a classic kind of bedside to bench sort of disease where we know what goes on clinically. We keep trying to create better animal models to mimic that. And again, the Scandinavians were pioneers in that area as well. And biomarkers for TBI, which I'm going to talk about more in the next few slides, but they were the first ones to incorporate biomarkers into guidelines for management. And here's a great paper from Urban Ungerstedt about microdialysis. You talk about the ultimate sort of biomarker of precision medicine, you know, being able to put a tiny catheter in your brain and measure extracellular concentrations of various substances. So as Mike said, I actually did my residency at VCU in Richmond, and then went to Texas and just came back about a year ago. And as they're trying to rebuild the research effort in that department, we're putting a lot of our emphasis on biomarkers, again, building upon a foundation laid down by some of our Scandinavian predecessors. Now, this is somewhat of an aspirational slide, but the thought here is that different parts of the neuron, the cell body, the axon, the myelin sheath, the vasculature, you can identify in the blood different compounds that may relate to this sort of microanatomy, to different parts of the cell. And if you really want to get aspirational, this is time here, minutes, hours, very early after injury, going on to months and years. You can see how some of these markers seem to go up fairly early and then come down. Others, though, the sort of chronic inflammatory phase, which we're just becoming more aware of, may be best diagnosed by a different set of markers. So there's a lot going on here, not just blood-based markers, not just TBI, but this is an area that we're working on, and Mike and I have talked about collaborations across the Commonwealth, trying to build on some of this. In terms of being maybe a little bit more precise, this is the ratio of GFAP, glial fibrillary acidic protein, to UCHL1, ubiquitin C-terminal hydrolase. And you can see that for diffuse injury, the ratio is low, but it's higher in mass lesions. And this may be the first branch point. You know, instead of lumping all TBI together, at least try to separate out those people who need to go to the operating room from those who don't. And there are some class 2 type evidence that supports that type of thinking. Now, this is even more interesting, I think, predicting brain injury. So this is an example using a ruptured aneurysm in stroke, where there's a somewhat high risk that the patient may go into vasospasm and develop ischemia in the brain. So you can measure things before that happens. We've also done some work when I was in Houston looking at this in brain injury. And wouldn't that be fascinating if you know that this patient has a higher risk of developing brain swelling in the next 12 or 24 hours? Maybe you can tailor your treatments or monitor them more closely or do something to try to nip that in the bud. And finally, this is an article that got a lot of attention. It came out in JAMA Neurology earlier this year, Linda Papa and her colleagues at Orlando. There's a lot of stuff on the slide, but what she did is she looked at patients in the emergency department with mild or moderate TBI versus trauma patients who didn't have that, and just collected serial biomarkers. And this is the overall patient cohort. You can see these are the ones who had TBI and these didn't. The blue line is GFAP, and this orange one is UCHL, UCHL1. So you see that those two biomarkers behave differently in patients who have or don't have brain injuries, and they have different time courses, which may help you discriminate a little bit, maybe be a little bit more precise. These are patients who had abnormalities on CT, and these are the ones who wound up requiring a neurosurgical intervention. So again, we're just scratching the surface. And of course, it's not going to be just one biomarker. It's almost certainly going to be a panel. And the best analogy of this, of course, is if you think you're having a heart attack, they will draw your blood and send it for certain enzymes. And those of us who've been doing this for a while have seen that evolve. So troponin is currently the one of choice. It's always bothered me because we can do this for the heart, but not the brain. And as a neurosurgeon, I always need to point out that if you could remove it or transplant it, it can't be that important. So finally, in terms of at least looking at the molecular biomarkers and other ways to try to differentiate our patients, what are we looking for? I mean, if I had a wish list, what would I want addressed on that list? Something that's portable, because these patients are really sick in the ICU, and they've got lines and tubes coming out of everywhere. And it's very well documented that transporting patients is a bad thing. You know, so one of my colleagues says, all death begins in radiology. Now, maybe that's been mitigated somewhat by the advent of these portable scanners where you can bring the machine to the patient and not have to put the patient in the elevator and go across the hospital, but it's still not a benign thing. You want something real time. So for example, microdialysis is great, but depending on your collection epochs, you may be delayed half an hour to actually seeing what just happened in the brain. You want something non-invasive. Right now, we actually have to drill a hole in someone's head, put something in the middle of their brain to get a lot of our data. And that's obviously pretty labor intensive for the physicians, and that poses some significant risk to the patient. Sensitivity, specificity, of course, there's that trade-off. It's easy to find markers that go up, but the key thing is testing them clinically and seeing what their value is over time. And finally, predictive value. I mean, that's the most fascinating thing about this, right? It's like your own little time machine where you know that in a few hours this patient's going to get sick. So if we get markers that go up before that happens, that could revolutionize the way we approach these patients. Now, all this doesn't apply just to biomarkers. I mean, this could also apply to imaging, and we've seen some great presentations at this meeting so far about MRI and the way that's going. The problem is that's pretty resource intensive. And if you think about something that can also be applicable in developing countries or that may not have a lot of technology, the military is interested in very far forward applications in the field, you're probably looking at a finger stick or looking at some other easily accessible specimen from the body to develop some of these. So finally, let me again thank you all for making a long trip. And I got to point out that I have indirect connections both to Scandinavia and to Virginia. So my parents came from there, from Lithuania after World War II. So we're not quite part of Scandinavia, we're just across the water.
That's the Nordic.
Huh?
That's the Nordic country.
Yeah, I've just been told it's a Nordic country, so I'm now in the club. Thanks. And finally, this is Virginia, where I trained and came back, but my wife's mother swears that she can trace her ancestry all the way back to Jamestown in the early 1600s. So, as I said, indirectly I'm connected to both these places. So thank you all for coming, and I look forward to the questions.
Thank you, Alex.